Okay, in this lecture, we're going to look at pregnancy, how that affects the woman's body, as well as how the pregnancy affects the dynamics within the family unit. So, the diagnosis of pregnancy is mostly based on symptoms. So, there are different signs. You've got presumptive, probable, and positive signs. So your presumptive signs of pregnancy are going to be those subjective changes that the woman is going to report. Amenorrhea, meaning that she has not had a menstrual cycle, she has missed a menstrual cycle. She may come in stating she's got, nausea, vomiting. They may be fatigued. They may report urinary frequency. Um, you've also got breast changes and skin changes. So their breasts may become tender. They may feel a feeling of tingling or fullness. Then they may also report some changes within their skin. Pregnancy will usually cause an increase in pigmentation. So they may have that linea nigra, which is that line, the dark line from the belly button on down. They may report that their areolas have become darkened. And then you've got Chadwick's sign. And Chadwick's sign is where the cervix or the vagina, the labia, those tissues in that area will change from a pinkish color to a dark bluish, purplish color. So for your probable signs, those are going to be some of the objective findings that the examiner will notice. So they may have a positive pregnancy test. They may come in, and a Goodell sign is going to be when they're examined, you take note that their cervix has softened. Hagar sign is when they do the exam. You'll notice that the lower uterine segment, it's able to be compressed to like a paper thin kind of consistency. Ballottement, that would be where if there's a fetus in there, if you were to tap the cervix during the exam, that fetus would kind of float away from its position and then kind of rebound back. So that movement is what's known as ballottement. Your Braxton Hicks contractions, those are just going to be irregular contractions, and a woman can experience those throughout the pregnancy, but they may not notice them, whereas some may. And then you've got your abdominal enlargement. So if you look at your presumptive and probable signs, there are other different disorders that could be ruled out. So another thing to take note of for your pregnancy test is that you want to use the first void. That will be the first morning void is the preferred specimen sample, just because that urine will be the most concentrated with the HCG, which is what's used to actually detect the pregnancy. So for your positive signs of pregnancy, there's only 3 signs that are accepted as a positive confirmation of pregnancy, and that's going to be auscultating fetal heart tones, detecting fetal movement, or actually visualizing that embryo or fetus via ultrasound. So now we'll look at the effect that a pregnancy has on the woman's body. So with respects to her cardiorespiratory system, the heart muscle will actually enlarge, as well as the total volume, the total blood volume will increase. So there are a couple of reasons that the woman's total blood volume increases. For one, she's going to be trying to transport nutrients and oxygen to the placenta so that those things become available to the fetus. She's also going to be trying to meet the demands of her expanding uterus, breast, just maternal tissues. And then her body needs to kind of provide a reserve to protect that woman against any adverse effects related to blood loss that usually occur during childbirth. Her oxygen consumption needs will also increase. And a term that you may hear during pregnancy is called physiologic anemia of pregnancy. And that is just where there's a dilution of red blood cells related to the expanding plasma volume as well. So there's not necessarily a decline in the number of red blood cells. So it's not a true anemia, but lab values may reflect that. With respects to the gastrointestinal system, the woman may experience an increased appetite, or she may have nausea. Some women have nausea initially, and then once that period passes, then they experience the increased appetite. With respects to the GU urinary system, the woman is going to be at an increased risk to develop urinary tract infections. So the bladder capacity will double, bladder tone, will decrease. But as the uterus enlarges, it may exert more pressure on that bladder. So women may experience increased frequency and urinary urgency throughout their pregnancy. Now, with respects to the woman's integumentary system, there are a couple of things. So she may experience these hyperpigmented areas. So melasma is a term that is called the mask of pregnancy, and it's usually areas of pigmentation around the forehead, the cheeks, or the bridge of the nose. The linea nigra is going to be that dark line extending from the symphysis pubis up the middle of the abdomen and can go, to the top of the fundus. And usually those hyperpigmented areas will disappear after childbirth occurs. Striae gravidarum, that is just a fancy term for stretch marks. So usually 50 to 80% of women will experience some type of stretch marks. Those do not disappear after childbirth. They may fade, but they don't usually disappear. Then some of the musculoskeletal changes that a woman may experience. She may have this waddling gait of pregnancy. So as the uterus increases in size, the female may, kind of need to lean back to maintain her balance. And so that creates a curvature of her lower spine, which can also lead to a backache. Now, diastasis recti, that is where your abdominal muscles become stretched beyond their capacity to maintain. And so you'll see that there's a separation of those abdominal muscles. So the severity of that just depends on the person. So now we'll look at how the pregnancy has an effect on the woman's psychological response. So during that first trimester, the woman is usually unsure as to whether or not they're even pregnant, and they're taking means to kind of confirm that. So they have that period of uncertainty. Then, they may have even conflicting feelings as to of their reaction to being pregnant. They may worry about their responsibilities. They may worry about how that pregnancy is going to affect their relationship, whether it be with their other children, their partner, their parents. Usually that ambivalence will turn into acceptance by the time they get into that second trimester. So also the first trimester is the time where the woman is going to primarily focus on herself, not necessarily the fetus. So during that first trimester, that's when a lot of the physical changes are happening, where she's got the nausea, the fatigue. She's got, just she may be having episodes of mood swings, and so she's just very concerned with trying to take care of her own physical and psychological needs. So then once we get into the second trimester, and a lot of those different physical issues that the woman may be going through are usually going to resolve themselves. So this is also usually a time where she'll feel that quickening, which is just the mother feeling the baby move. And this time during the second trimester, that's usually where she starts to experience that uterine growth, so that the pregnancy starts to feel real, look real, and her focus will then turn to the fetus. So she's more concerned with fetal development and how her diet or how her activities may affect the fetal development. She may have some of those body image changes as well. Just how she views herself, as far as with getting the hyperpigmentation, getting the stretch marks, those things could have a negative impact on the woman's body image, self body image. And then finally, in your second trimester, you've got some changes in a woman's sexuality. And so that's very different from patient to patient. You may have some women that have an increase in sexual interest in the first trimester because they don't necessarily have to worry about getting pregnant now. But then you've got others that they're experiencing that nausea, vomit, and fatigue. So that is kind of interfering with that sexuality. And then it goes into the second trimester when those issues resolve and they have more energy, when they become more interested in sex. And then once you get into the third trimester, the woman is going to be, her uterus is larger. Now she's starting to have those physical symptoms again. She's got that abdominal pressure, heartburn. When they lay back, they may become hypotensive. So a lot of different things at that point can kind of make it difficult to have sex. So it may be the different positions. They may have some difficulties in getting in certain positions. From a nursing standpoint, you can, let your patient know intercourse is safe throughout the pregnancy as long as there are no other complications. So if a woman starts having bleeding, preterm labor, rupturing of membranes, or if their cervix is deemed to be incompetent, meaning that it's not wanting to stay closed for the duration of that pregnancy, those are all some complications where it would be determined that the female should not engage in any sexual activities for the remainder of that pregnancy. So then moving into that third trimester, you see more vulnerability, where the female becomes more concerned with her well-being as well as the fetus's well-being. There's an increasing dependence of the woman on her partner, whether it be physically, because now she's larger, it's and more fatigued again, so it's hard to climb upstairs, it's hard to tie your shoes, it's hard to reach different things. But then also that psychological dependence, they start needing more love and attention from their partner during this time as well, and that could go back to some of the body image issues. The couple may start trying to prepare for birth. They may become a little bit more anxious about trying to find out, how long it's going to take to get to the birthing facility. Uh, Also, in that third trimester, many women start, they grow tired of being pregnant and they get to the point that they're just ready for that pregnancy to be over. Another thing you may see is nesting behavior. And so nesting is where the woman starts to prepare her home, like getting clothes, getting furniture, making sure the baby's got somewhere to sleep, just starting to divide up tasks among her and the partner. So you may see some nesting behavior as it gets closer to time for delivery. So now we're going to look at how the pregnancy kind of affects the different family dynamics. So first we'll start with the paternal role. So the partner or the spouse, they may actually struggle to be recognized as a parent. So it may be um, that they feel like they're being viewed as a helper as opposed to a parent. So you can, as a nurse, you can encourage your OB patient to kind of just express and share their feelings, emotions, and any physical symptoms they're experiencing. They can share that with their partner so that they help the partners to feel like they're a part of the whole pregnancy process. Also, as a nurse, you want to try to view your the patient, the fetus, and the partner as one patient. So the mother, the fetus and the partner as one patient. Kind of focus on them as a whole when you're caring for them. And then just making sure that the spouse and the partner are included in your education, in your information that you provide about infant care and parenting. Another term you may see is called KUVAD, and that is basically sympathy pain. So, where the partner may experience some pregnancy related symptoms similar to those of the pregnant woman. So, it may be the partner has a loss of appetite, or the partner is actually having nausea, vomiting, or they have a headache, or they're gaining weight. So, those that incorporates that term, KAVAD. Now, the reaction of the grandparents depends on a few of the factors. It may depend on their age. It may depend on how many other grandchildren they already have, and also their perception of what their role is as a grandparent. So, as far as age, your older grandparents may be a little bit more excited and happy as opposed to your younger grandparents. Younger grandparents may feel that, they're too young to be a grandparent. They have not necessarily dealt with their own feelings with respects to aging. The number and spacing of other grandchildren, so that it may, if this is like the first grandchild, there may be a great deal of excitement, whereas if it's the fifth, 10th, 15th, they may, still welcome the grandchild, but they may not be as excited as if it were their very first grandchild. And then their role perception, that is just the grandparent trying to figure out how they fit in, how they can help the parents. They may not want to, quote unquote, overstep a boundary, but just kind of, as a nurse, you can help those families kind of talk through those feelings and identify those roles. The response of your siblings to a pregnancy also kind of varies by their age. So your toddlers, those that are like 2 years or younger, many times they're unaware of the different changes that are occurring during pregnancy. Once the baby is born and brought home, it may be that those toddlers show signs of jealousy or resentment towards that baby. So it's just important to help those parents to know that they should just constantly reassure the toddler that they are also loved and they are also a part of the family. They're not going to be displaced in any aspect. And some of your older children, your school age children, they may be more curious. They may understand a little bit more of what's happening with the pregnancy and be more aware. Um, so they may want to be included in, preparing for the baby. They may ask questions about, how the the birth and the newborn may actually affect their role within the family unit. So your school age children, they are the ones that the sibling classes are usually targeted towards. Your adolescents, they they kind of vary depending on their developmental areas. Some are indifferent to pregnancy, and then some adolescents are actually embarrassed. And they may be embarrassed because if you think, in adolescence age, they are a little bit more aware of sexuality. And so a pregnancy actually kind of confirms that, their parents are still sexually active. So that could be an embarrassment for them. So then looking at divorce and blended families, it may be that you're having to discuss, how a newborn will fit into a family where the other siblings are not all, the biological children of the two partners. So that may be something to address, and it's just making sure that everyone's able to discuss their feelings and that no one feels displaced or no one feels better than or less than the baby or the changes that are occurring. So, and then you've got some of your abnormal situations, whether it be domestic violence, substance abuse, or actually a death of one of the partners. With your substance abuse, just making sure that you're trying to educate the patient as to the effects of that abuse on the developing fetus, and then trying to monitor them throughout. And it may be that they need a social services consult, so that they can determine whether or not it's even safe for that infant to be released into that home. Same thing with your domestic violence. Going back, to module 1, just making sure that you're assessing for those signs and symptoms of abuse, and that you are reporting and trying to help reduce those instances for those patients. The death of a partner is another special circumstance, and it may be there that you're just having to do that active listening. You're trying to help the patient go through those stages of grief, depending on what part of the pregnancy, what trimester they're in, um, where they are with their stages of grief with respects to their pregnancy development, trying to make sure that you're taking care of the physical pregnancy and fetal development needs, but also helping that patient go through those stages of grief as well. And that will conclude our pregnancy adaptations and effects on the family dynamics.